Welcome to MED-MYSTIFY. In this explainer, we're going to explore the absolute miracle that is the biological cascade of blood clotting. And more importantly, we'll look at the powerful coagulant drugs that step in to support it when things go wrong. Okay, let's dive into our roadmap for today. We're going to cover the miracle of coagulation, the 3 clotting pathways, classifying coagulant drugs, their clinical uses, and finally, we'll do a deep dive into some specific drug profiles.
Part 1. The miracle of coagulation, stopping the bleeding.
Hemostasis is an absolutely vital biochemical reaction. It's basically our body's built-in defense mechanism that ensures we stop bleeding whenever a blood vessel gets damaged. Without it, we'd be at constant risk of severe hemorrhage. But on the flip side, if it overreacts, we face the dangers of thrombosis or an embolism. It's this delicate, perfect biological balance. But what happens when our natural balance fails? That's exactly where coagulants come in. These are therapeutic agents used in hemorrhagic conditions, and they step in to help blood coagulation by providing the essential clotting factors normally found in fresh whole blood or plasma. We use them when a patient has a deficiency of a specific clotting factor and literally needs a pharmacological helping hand to stop the bleeding.
Section 2. The 3 clotting pathways, the domino effect of hemostasis.
To really understand how these drugs work, we first have to grasp the domino effect of hemostasis. Coagulation isn't just one simple step, right? It's a highly complex biological chain reaction. I like to think of these pathways as 2 converging highways. First, you've got the extrinsic pathway. This is the rapid route. It gets initiated instantly by tissue injury, exposing what's called tissue factor, or factor 3. Then you have the intrinsic pathway. This is the internal route, triggered by contact activation involving blood components that are already hanging out right there in your bloodstream. And both of these highways, they are racing toward the exact same destination. Let's trace that internal route a bit closer. The intrinsic pathway is a literal cascade. First, factor 12 gets activated to 12A. That triggers factor 11 to become 11A, which then activates factor 9 to 9A. And this brilliantly illustrates the complexity of our biology here, because factor 9A then combines with factor 8A, calcium, and phospholipids to form something called the intrinsic 10-assay complex. This powerhouse complex really has one main job, activating factor X to XA. And that brings us right to the central intersection, the common pathway. Remember those 2 converging highways we just talked about, the rapid extrinsic road and the complex intrinsic road? Well, they both meet right here at the activation of factor X. This is the crucial convergence point where the real heavy lifting of blood clotting actually begins. From factor XA, we trigger what is arguably the most important reaction in the entire cascade. It's the big climax. Prothrombin converts to thrombin. Now, thrombin is the absolute central enzyme here. It is the star of the show that amplifies everything. It takes fibrinogen and converts it into fibrin, which ultimately weaves together to form that life-saving, stable clot. But, this cascade doesn't just operate in a vacuum. It requires some vital cofactors to get the job done. Calcium, also known as factor 4, is essential at multiple stages of this process. And vitamin K, absolutely critical. It's required by the liver for the synthesis of factors 2, 7, 9, and X, as well as protein C and S. Together, these cofactors ensure the final fibrin network can successfully trap those blood cells and form a stable hemostatic plug. So this entire cascade is a marvel of nature. But what happens when we need to medically support this process? When nature's cascade falls short, how do we step in pharmacologically?
Section 3. Classifying coagulant drugs, the pharmacological interventions.
When a patient's natural cascade is failing, maybe due to a severe deficiency or an underlying condition, we have to rely on pharmacological interventions to restore that perfect balance. Now, what's really interesting here is how we categorize these interventions, specifically focusing on vitamin K. We have K1, which is plant-based and fat-soluble, like Phytonadione. Then we have K3, which is entirely synthetic. Notice how K3 actually splits into fat-soluble forms, like Menadione, and water-soluble forms, like Menadione sodium bisulfate. This beautifully organized matrix gives clinicians the exact options they need, depending on a patient's unique absorption capabilities. Beyond vitamin K, there are several miscellaneous coagulant drugs we can use to intervene. These include human fibrinogen, anti-haemophilic factor, desmopressin, adrenochrome monosemicarbazone, ruthin, and ethamsylate. Each one of these plays a highly specific role in targeting different breakdowns within the body's hemostatic process. Section 4. Clinical uses of coagulants. When to medicate. So we know what the tools are. Let's explore exactly when to medicate. When are these diverse pharmacological interventions actually deployed in the real world? Well, there are 4 primary scenarios requiring coagulants. First is prolonged antimicrobial therapy. Believe it or not, taking antibiotics for a long time can actually destroy the good gastrointestinal bacteria that naturally form vitamin K, meaning we have to proactively replace it. Second is obstructive jaundice, which causes a malabsorption of dietary vitamin K. Third is the overdosage of oral anticoagulants, where vitamin K acts as a specific life-saving antidote. And fourth is general malabsorption syndrome, which is usually treated with parenteral vitamin K or oral K3. If we zoom in on that third scenario for a second, anticoagulant overdose, the choice of drug is entirely a matter of time. Vitamin K1 is the absolute preparation of choice here because of its rapid onset of action. It works fast, exactly when every single second counts. On the other hand, vitamin K3, specifically mendiol sodium diphosphate, should absolutely not be used in an overdose situation. Why? Because it has a highly delayed onset of action, up to 24 hours. And in an active overdose, you simply don't have 24 hours to wait around.
Section 5. Deep dive specific drugs. Menadione and acetomenadione.
Zooming in closely on the prominent synthetic profiles of menadione and acetomenadione really helps us understand exactly how they function inside the body. First up is menadione, commonly found under trade names like capelin and canadian. This is a synthetic naphthaquinone, and what's absolutely fascinating is its mechanism. It actually converts in vivo, so inside the body, to the active vitamin K2, known as menaquinone, via alkylation. It's primarily used to support the normal blood clotting process and assist in normal bone calcification. But keep in mind, even though it's a precursor for various forms of vitamin K, it is specifically not used as a daily nutritional supplement. Now, like any powerful intervention, menadione comes with potential side effects, ranging from major to minor. We can group these logically to see how they impact the body. You might see dermatological and autonomic responses, like a skin rash and excessive sweating. Systemically, patients might report muscle stiffness, general tiredness, dizziness, or chills. And in more serious instances, it can cause difficulty breathing and chest pain, along with gastrointestinal issues like nausea, vomiting, and abdominal pain. Just to quickly wrap up menadione's side effect profile, a few other things to actively watch out for include a decreased appetite, severe headaches, flushing of the face, a dry mouth, diarrhea, and localized pain right at the injection site. It's a robust drug for sure, so monitoring these effects is key before we consider our next pharmacological option. And that brings us to acetomenadione, often known by the trade name rutin. This is a menadiol diacetate, which is essentially a vitamin K analog. Its primary biological job is to prevent hypoprothrombinemia caused by a deficiency in vitamin K. Clinically speaking, it has 2 incredibly vital roles. First, it's heavily used to treat hemorrhagic conditions in infants. And second, it acts as a direct, powerful antidote for coumarin anticoagulants. While highly effective, acetaminophen's side effect profile definitely requires careful attention. Patients might experience transient flushing, strange alterations in taste, dizziness, diaphoresis, which is just intense sweating, dyspnea, brief hypotension, cyanosis, and irritation to the skin and respiratory tract, along with general hypersensitivity. But the absolute most crucial side effect to emphasize here is the very real risk of hyperbilirubinemia, specifically in premature infants. That is a serious, vital consideration when we're treating our youngest and most vulnerable patients. Which leaves us pondering a critical question. Ultimately, how do we master the delicate balance between the natural clotting cascade and pharmacological intervention? Hemostasis is a brilliant, life-saving biological domino effect, but managing it when it falters, that requires immense precision, vigilance, and a deep understanding of these incredibly powerful drugs. Like, subscribe, and share this with your friends for such more pharmacy-related informative videos. Be sure to write your questions, suggestions, and thoughts in the comments section. We will catch you in next one.